an elevated temperature, an elevated white blood cell count, and nausea and vomiting. Acute appendicitis is a dangerous condition because the inflamed appendix can become gangrenous or rupture. Rupture can result in peritonitis with bacterial contamination of the peritoneal cavity. Peritonitis is more common in older adults. Signs of peritonitis include a rigid, board-like abdomen, abdominal pain, absent bowel sounds, fever, and dehydration. The diagnostic tests for appendicitis include a white blood cell count and a CT scan of the abdomen, or an abdominal ultrascan. The client's white blood cell count is elevated, and the CT scan indicates an enlarged cecum. What are the nursing diagnoses for clients who have appendicitis? Acute pain related to inflammation of the appendix. Nausea and vomiting related to the acute inflammatory process. Risk for fluid volume deficit related to nausea and vomiting. Risk for infection related to possible rupture of the appendix and peritonitis. And anxiety and fear due to the possible rupture of the appendix and peritonitis. The treatment for acute appendicitis is either a traditional or a laparoscopic appendectomy. Prior to surgery, the client should be placed in semi-Fowler's position and should receive nothing by mouth. Administer IV infusions as ordered to prevent dehydration and as a route for analgesia as needed. It is important to remember the following. Do not administer laxatives or enemas preoperatively, as these measures can cause perforation of the appendix and peritonitis, and do not apply heat to the client's abdomen, as it can worsen the inflammation. During surgery, the surgeon will remove the appendix through a small incision or by means of laparoscopy. Surgical drains will be inserted if the client has developed an abscess. If peritonitis has developed, the surgeon will insert a nasogastric tube to prevent gastric distension. Following surgery, place the client in a semi-Fowler's position and encourage early ambulation if not contraindicated. Advise the client to avoid heavy lifting for several weeks following discharge. If perforation has occurred, administer IV antibiotics as prescribed to control the peritonitis. Be sure to monitor the nasogastric tube and gastric drainage and provide meticulous wound care. What acid-base imbalance is a client at risk for when an NG tube is connected to suction? Metabolic alkalosis, because acids are lost through aspirated gastric contents. Gradually increase the client's activity level until he is fully ambulatory. Now, let's turn our attention to inflammatory bowel disease. IBD is a chronic inflammatory disorder of the intestinal tract that is characterized by remissions and exacerbations. There are two forms of IBD, Crohn's disease and ulcerative colitis. Crohn's disease, or regional enteritis, is characterized by chronic recurrent inflammation of the mucosa of any segment of the bowel, but primarily the terminal ileum. Regional enteritis is limited to the small bowel. Lesions develop and ulcerate, causing abscesses and fissures in several segments of the bowel. As the disease advances, the bowel wall becomes severely fibrosed, thickened, and narrowed, which will affect the client's nutritional status. With Crohn's disease, the intestinal changes affect the small bowel. What is the client at risk for? Nutritional deficits, since the small bowel is where most of the nutrients are absorbed. Ulcerative colitis is characterized by diffuse inflammation of the mucosa and submucosa of the colon. The inflammatory process causes thickening and edema of the mucosa of the large intestine and the rectum. Chronic inflammation causes bleeding. Abscesses may form and become necrotic. The client might also have bloody stools. As a result of the chronic inflammation, the colon becomes shorter and narrower due to scarring and fibrosis. The etiology of IBD remains unknown, but researchers have identified some possible risk factors. Infectious agents, viruses or bacteria, an autoimmune reaction, food allergies, heredity, exposure to stressful situations, race. Since IBD is more common among Caucasians than among African Americans or Asians, and ethnic origins, since IBD is more common among Jewish people than among people of Middle European origin. The signs and symptoms of Crohn's disease and ulcerative colitis are similar. Diarrhea. With Crohn's, it can be severe and usually non-bloody. With UC, up to 20 stools a day with blood. Abdominal symptoms. With Crohn's, intermittent abdominal pain, abdominal distension, and flatulence. With UC, abdominal cramping, abdominal distension, and left lower quadrant pain. Fever. With Crohn's. Fever is intermittent with UC. Fever develops during acute attacks. Appetite. With both anorexia, nausea, and vomiting. Weight. With Crohn's. Severe weight loss. With UC, weight loss is common. Fatigue. With both, there is fatigue. Tenesmus. With Crohn's. It is rare with UC. It is severe. Nutritional deficiencies. With Crohn's, it is common. With UC, rare. The diagnostic tests for IBD include stool examinations for blood, mucus, and pus, stool cultures for microorganisms, CBC, differential, hematocrit, hemoglobin, barium enema studies, colonoscopy or proctoid sigmoidoscopy, and biopsy of intestinal tissue and cytologic studies. What are the nursing diagnoses for clients who have IBD? Diarrhea, related to acute inflammation of the intestinal tract. Pain, acute or chronic, related to the inflammatory process. Altered nutrition, less than body requirements related to nausea and vomiting. Fluid volume deficit, related to severe diarrhea. And coping. Individual, ineffective, related to the severity of intestinal symptoms. IBD is treated with medications, rest, diet, adequate fluids, stress control,